Okay, thank you so much. We have heard a lot already about distraction in different areas, and I will go a bit back to the basics to explain these distraction techniques with a short focus on posterior cranial vault, because tomorrow it should be a basis for tomorrow for the hands-on workshop where we have distractors available and some 3D models which you can have, not only Paul Tessier like them to have in the hands, but also we as handcraftsmen like to have these models. So we will go a bit into distraction techniques, and I have three main things which we will discuss. Is the basic principle of distraction, what is that, and why these distraction principles are interesting for craniosynostosis, and then we have heard already plenty of approaches, surgical approaches, and different type of distractors. Maybe just summarize these different types. And to go back to history, Codivilla tried this distraction and described this early on, actually cutting the bone and then pushing the bone or pulling the bone apart, and they did this with plaster casts, and this was actually a problem because this caused pressure necrosis, but they could lengthen bone by gradual distraction. And then later on, it was Ilizarov, orthopedic surgeon, who popularized this distraction, and he did a lot of studies in animal models, and these actually findings about how fast we should put bony parts away, how fast, what rate, what rhythm is still true for nowadays. But he did that in Russia in a lot of patients, but it was only known in Russia. And it was then only after we heard McCarthy already with the rib grafts for the fronto-orbital advancements. Snyder tried that in the canine mandible, and if you have a look at this, it looks quite similar still today. And McCarthy had this patient with a hemifacial microsomia, airway issues, feeding problem, and he did a distraction of the first craniofacial distraction on this mandible in this patient. And he termed also, or it's not only about osteogenesis, so we not only create bone, but we also do a histiogenesis. We can promote growth of other tissues also. And the principle has not changed since then. Maybe the indications have, but the principle is still the same. And the question is, where can we use that, and why it's interesting in craniofacial surgery, especially for craniosynostosis. We heard a lot from previous talk about this skull base, and I found this interesting, and you mentioned it before, that actually a big problem in these patients with syndromes is that the skull base sutures are fused, and this then has implications and explains also the phenotype of these patients. So we can not only explain the cranial changes, but also the facial changes with this exorbitism, airway problem, feeding problem. So we have to address this complete deformity. And we heard also posterior cranial vault first to address first different possibilities, doing a high but also lower osteotomies. We heard in previous talks also about the advantage of pre-surgical planning, virtual surgical planning, to see where we want to cut, to use patient-specific implants at the areas where we have enough bones, and then the discussion, should it be high, should it be below? The torcula also there, for me, what was once interesting to see that it was not intuitively as we would have expected, that if you do the osteotomy far below, you gain more volume. It was the opposite around, which the colleagues in Birmingham showed. So this is one possibility to apply distraction techniques in the posterior vault. And then for us as maxillofacial surgeons, interesting, why is this? How can we promote growth in which is restricted due to synostosis of this skull base? And skull base is important, a promoter of facial growth. And if this does not happen, we have seen in the talks of the ophthalmology, of the pneumology, but also for functions, orofacial functions, we have big implications. And at some point, the question is, when do we need to address these problems and help these patients in growth. And we have heard about mid-phase distraction, which is possible by external distractors at different levels, from LeFor-3 level, LeFor-2 level. And with these distractors, we move the facial skeleton to a direction. And we can use external distractors, as we have seen, but also the ones we have seen with complete internal distractors, or combine external with internal distractors, the one pushing and the other one pulling. So do a combined approach. So different techniques and approaches can be combined here. And why do we have different techniques and might need to go for one or the other? It's because these external, rigid external distractors, they might cause complications, penetrations in falls, but also described during removal of these distractors if they have tension, potential penetrations of these pins and infections. So this might be lead to more internal applications or other applications, and we have seen, I think, also in some talks, this starfish patient-specific foot plates to be used in patients which have a limited amount of bone or lack of coverage. And then how does this work? Actually, the concept is still the same. You have a rhythm and the pace you activate, and often, or for me, this was also something you needed to learn, that actually the adherence or compliance of the kids are quite good if you explain how these work. And so the idea is that they work with you doing the treatment afterwards. So parents and patient. And just an example of a LeFor-2 level distraction before with this phase, which because of the airway issues, we did a LeFor-2 distraction, and then you can move the facial skeleton forward. And the question then was, when I was preparing the talk, okay, is it only about the cranium and mid-phase? What about the mandible? This is something we might have or bear in mind, that actually also the mandible is different in these patients. And you mentioned it before that also if you look at the orbit, it depends when you it might be important when to interfere or help for future growth, because what is shown that actually the vertical dimension of these mandibles is normal, but the length of the mandible is not. And in other studies, they showed that depending on when and how you move the midface, you will also have changes in mandibular position. So this is another point of secondary deformity, and we should have in mind that maybe if we do a very late correction of the midface, then also the mandible might need to be addressed at the end. So I hope that I could summarize a bit this distraction, osteo or even histiogenesis with bone regeneration after an osteotomy and then gradual distraction, and explain why it is interesting in syndromic craniosynostosis, mainly because of these skull-base sutures, which are important for facial growth, posterior cranial vault distraction, whether it's with free-floating springs or internal, external distractors, then frontofacial monoblock from the Necker team. We have heard and midface distraction at different levels, but also have in mind that mandible might need to be looked at the end of growth. Thank you.